Thank you, Julia. And it's a great privilege to be here to add my congratulations to the three honorees. I think Bill Benson, for all of us in retina, is someone who, early on you read his books on retinal detachment and you look at the Benson rules, and so I think everybody is very well familiar with them. And Al Lucier is another pillar in ophthalmology, and Gary Brown, I think, as well. I have to tell you a quick Bill Benson story. When I was just starting out, and I just joined the faculty at the University of Virginia, Bill came down to give one of the featured lectures, and it was right around the holiday season. So we had a holiday party, and Dora Conway, who was always very good about having nice surroundings and everything, had a beautiful setup where she had candles in the windows. And Bill came up to me and said hello to me and said, "Hi, Peter, how are you?" And I was so shocked that he knew my name. And he was always that way, that, his younger colleagues, he paid attention to who you were and what you were doing. So we were talking, and I was just sort of mesmerized by his wonderful conversational attributes. And he sort of backed me up against a window, and then suddenly we smelled something burning, and my wife suddenly started hitting me in the back, and so she quickly pulled me away, and I had to excuse myself from Bill. And I had my brand new suit on, and there was this big burn mark in the back. So metaphorically speaking, Bill really sort of ignited my interest in ophthalmology. And my wife has done everything she could to try to put it out. Here's my potential conflicts of interest. Now, I think, as Joe McGuire just pointed out, and really set the stage, the background of this disease, we know that there's a lot of retinal hemorrhages that can cause vision loss initially, and that's reversible. There's macular edema, which causes vision loss and is initially reversible, and there's macular ischemia, which the dogma has always been it is permanent. Then there's also loss from secondary complications of the vein occlusions. And he pointed out the results of Bravo and Cruz, which were excellent and showed that with anti-VEGF treatment compared to sham, there was a very substantial improvement. And then when you go to PRN, there's an improvement in the sham group and continued stability in the VEGF group. And for central vein occlusion, it's very similar, but as he pointed out, there really was not a complete catch-up at 1 year. Well, those results really are just the very beginning of the story in vein occlusion, because naturally these patients, go on for years. And, we initially thought that that this might be an easier target than diabetic retinopathy or neovascular AMD, because once patients form collaterals, maybe the problems would resolve and everybody would be happy. But it turns out that that's not the case. And so we've gone on in our initial study that Julia mentioned, we've continued to follow these patients. We now followed them out for 5 years. And what we found at the 2-year time point was that in the PRN phase of the trial, this was monthly injections up to month 3 and then PRN. You can see that in branch vein occlusion, things were pretty well maintained. But in central vein occlusions, things pretty much fell off from their peak level. And the Horizon trial, the CRVO or the RVO component, looked at this for the Bravo and Cruz patients. And what you see there, again, in the BRVO patients, after 1 year of treatment, these patients then went to at least being seen at least every 3 months and getting injection. They could come in earlier if they or the physician felt it was necessary, but it was at least every 3 months. And with that protocol going out to another year, you see things are fairly well maintained, not completely with BRVO, but with CRVO, there's a substantial fall off. Now, one of the things that we really haven't completely ruled out is macular edema the only endpoint we should be following? And another endpoint is this non-perfusion, retinal non-perfusion. As has been pointed out, it's identifiable in some patients soon after occlusion. There's a variable amount of it. Some patients have a little bit, some patients have a lot. There's this archaic system that we use where we call patients either ischemic or non-ischemic. But as Joe pointed out, it's really a spectrum. It's from patients who have very little to patients who have a lot. The thing that has been demonstrated, though, is that it increases over time. And this has been shown in every study that's looked at it now, in the CRVO study, in the SCORE trial, and in Bravo and Cruz, that patients start with a certain amount, but then it increases over time. Now, how does ranibizumab affect this capillary non-perfusion? Well, we looked at this in the Bravo and Cruz patients, and this was done as a secondary endpoint with grading done at the Wisconsin Grading Center, and they used this reticule to look at the amount of non-perfusion in this central area. So it's the central subfield and the surrounding subfield. And you know, the reason to do this is that you really, at that time, you really couldn't grade way out in the periphery. But this is a reasonable sample to take. And what was found in that is that if you take the patients who had no central non-perfusion at baseline, it was about 80% in the Cruz trial. And in the sham group, you see that that decreases over time, so that they're getting increased non-perfusion, so the percentage of patients with no non-perfusion is going down. But in the ranibizumab group, it actually increases a little bit. And there's the statistically significant difference at 6 months. Now, at 6 months, when these patients are able to get ranibizumab, you see that the percentage with no non-perfusion increases so that this difference goes away. Now, it's interesting, with branch retinal vein occlusion, the amount of central non-perfusion is actually greater than those with central retinal vein occlusion. And probably due to the fact that the occlusion is more distal, so that there's less opportunity to get some collaterals or something that to compensate for this. Anyway, they have more non-perfusion, so only 60% had no non-perfusion at baseline. You can see in the sham group that this increased quite a bit. It doubled, so that only 30% at 6 months compared to just a modest decrease in the ranibizumab group, so that this was statistically significant. And then after these patients get ranibizumab, it goes away. I'll just show you a few examples. Here's a patient who at baseline with a branch vein occlusion, you see there's quite a bit of non-perfusion. Now, after 6 months of getting ranibizumab, you see that there's a substantial decrease in the amount of non-perfusion. Now, in the next 6 months, when you go to PRN, one of the things we learned from this is that these capillaries that reperfuse are very tenuous. And they're not really even maintained well unless the patients continue to get monthly injections. So if you go to less than monthly injections, many of these reperfused capillaries now begin to shut down again. Here's a patient from the sham group with central retinal vein occlusion, had really pretty good perfusion at baseline. But after 6 months in the sham group, you see that there's all this non-perfusion. And now the patient's put on ranibizumab PRN. It's not as good as monthly, but it's enough to cause some reperfusion. The vessels aren't completely normal, but they're reperfused. So, with retinal non-perfusion, the amount is variable at baseline, and it's important because the more non-perfusion you have, the more prone you are for more non-perfusion. So it's the amount of ischemia that seems to drive this increase in non-perfusion. This whole thing, the categories that we used to have are really outdated. It's really a spectrum. It's not an all or none. And this non-perfusion tends to increase over time. Now, in the SCORE trial, if you look at these groups from baseline to 4 months, and this grading was done by the Wisconsin Grading Center in the same exact way as what I just showed you, what they found was in all groups, taken as a whole, there was an increase of 200 to 400% over 4 months. And then from baseline to 12 months, it was 400 to 37%, so a 4-fold to 37-fold increase. In Bravo and Cruz, it was less than 100%, showing that, again, even a little bit of ranibizumab is better than no ranibizumab. Now, the old theory was, why does this non-perfusion increase? Because the occlusion is increasing. When you think about it, it really doesn't make a whole lot of sense. You know, this whole concept of a partial central retinal vein occlusion going to a complete retinal vein occlusion. What we now find is that because ranibizumab, an anti-VEGF agent, blocks the progression of non-perfusion, this means that it's VEGF that is the culprit. It's VEGF that is causing this worsening of non-perfusion. And the possible explanation is already been demonstrated in a primate trial in which Tolentino and Adamus did multiple injections of VEGF in primates, and what they found was non-perfusion that increased over time with the injections. So probably what's happening is VEGF promotes leukostasis. The white cells have a FLT receptor on it, VEGF receptor 1. VEGF recruits white cells in, so when you have very high levels of VEGF, you have recruitment of white cells into the eye, causing leukostasis and promoting non-perfusion. So let me just show you a few cases from our 5-month follow-up, our 5-year follow-up. This is a patient, 58-year-old Caucasian female, who had decreased vision in her left eye for 4 months. You can see there's a branch vein occlusion, and it may be hard to see here, but there's a fair amount of non-perfusion. After 3 months, getting 3 monthly injections of ranibizumab, the non-perfusion is not too bad, and the edema is not too bad. Here, after 1 month after stopping, there's worsening of the non-perfusion, and of course a lot of worsening of the leakage. Now, if you look over time, here at 30 months, you see there's even further worsening of the non-perfusion. Now with a wide angle, of course we don't have, I can't show you the wide angle earlier on, but you can see that all of this area is non-perfused. We've been looking at whether scatter photocoagulation, is beneficial, and I can't give you the answer today. In this case, you can see, though, that the patient received scatter and grid, additional laser, and it looks like things maybe are winding down in this patient. Here's another patient who had 2100 vision. You can see that this is a central retinal vein occlusion, some non-perfusion. After 3 ranibizumab injections, now less non-perfusion. But now the patient goes to intermittent treatment. You see over time the non-perfusion worsens. And here with a wide angle you see at 46 months this non-perfusion. And all this time this patient's edema has been worsening. This seems to be what explains that patients who are treated PRN or intermittently with anti-VEGFs worsen over time, and particularly patients with central retinal vein occlusion. With scatter photocoagulation, perhaps things wind down a bit. Again, I can't give you the final answer. We're now investigating in a controlled trial, looking at patients who get ranibizumab for 6 months, all of them monthly. Either it was actually a 2 milligram dose or a 0.5 milligram dose, but then after 6 months they're re-randomized to either scatter photocoagulation or not. And so hopefully I'll have an answer to you on whether this approach is beneficial in the future. But it's interesting to note that not all patients have this worsening. Here's a patient who has a central retinal vein occlusion, a relatively young patient, not very much non-perfusion. Even here, after 3 months, you see now he has leakage, persistent leakage after 3 injections of ranibizumab, but not much non-perfusion. Here, after 18 months, again, leakage, a little bit better, but not any non-perfusion. And then gradually, things just continue to improve with PRN treatment. You see the wide angle, again, not non-perfusion. And this patient, these are the kind of patients that we had hoped all of them would be like, that they just gradually improve with treatment and then get stabilized and don't need injections anymore. I can tell you now, after following these patients for 5 years, that these patients are a rarity. It's usually the younger patients, patients who don't have much non-perfusion or don't have much ischemia at baseline. and they, after a series of injections, stabilize, don't need injections anymore. But unfortunately, this is the minority. So my current recommendation, and it's not based on just what I showed you, but is to treat initially with ranibizumab for at least 6 months. I think aflibercept is equally good, and I think many people may go to that. If frequent injections are needed after this, if you go to some sort of PRN, I think it's worthwhile to get fluoresceins and to look at the status of non-perfusion. And at some point we're going to answer whether scatter photocoagulation is indicated, but for right now I think it's also reasonable to consider Ozurdex or Kenalog if you continue to require injections. With CRVO it's the same thing, only what I neglected to say with BRVO is to use grid laser therapy. So I'd like to just recognize our wonderful group of coordinators, particularly headed by Gulnar Hafiz, who make these studies possible, and then all of my collaborators at Wilmer who participated in these trials. Thank you very much.